This presentation is designed to reaffirm existing training to support operational crews who may be called upon to respond to incidents involving cardiac arrest. This presentation is not intended to replace regular hands-on training. If any doubt exists, crews must seek guidance from a suitably qualified trauma care instructor. Part 1 details the inventory of equipment available to crews when dealing with a cardiac arrest, as well as mannequins and equipment available for effective training. Part 2 details the correct sequence of events for treatment of a patient in cardiac arrest.
Reanalyzing heart rhythm.
An AED is an electronic device designed to be used by a layperson. It will automatically read the heart rhythm of someone who may have suffered cardiac arrest and diagnoses if an electrical shock is required to restore normal heart rhythm.
Shock advised.
If required, the AED will safely deliver a controlled electrical shock to the heart. Norfolk Fire and Rescue Service uses the iPad SP1 AED. The AED is a robust, self-contained, weather-resistant and largely maintenance-free unit. It has pre-connected self-adhesive smart pads, which are suitable for both adult and child. The iPad will analyze the patient's condition, and a series of visual and audible commands will prompt the user to perform the necessary tasks. This includes when to commence CPR,
Begin CPR now.
including an optional metronomic guide to ensure the correct rate.
Reanalyzing heart rhythm.
The AED can also detect whether effective CPR is in progress or not and prompt the user accordingly. When to shock, if appropriate.
Shock advised. Stand clear. Press the flashing orange button now.
When to interrupt CPR to allow the unit to reanalyze the patient.
Analyzing heart rhythm.
When to breathe for the patient using a bag, valve and mask. The volume of the audible prompts will adjust automatically to take account of ambient noise.
Begin CPR now.
The AED will perform daily, weekly and monthly self-tests, and the status indicator will show that the AED is functioning correctly and ready for use. A full circle symbol indicates the AED has successfully passed its self-test regime. An X in the window indicates that there is a fault. The unit has a 5-year battery life in standby mode, and a new battery must be ordered once the indicator displays 1 bar. The pads indicator shows the status of the pads. The half symbol indicates that the pads must be replaced within 3 months. The AED will store and record critical information such as test data, time in use, and number of shocks administered. This data can be retrieved using the SD card port if required. However, it is best practice to record this information manually during an event to provide the attending paramedic with an accurate medical intervention history. The accompanying sealed AED starter kit includes tough cut shears, prep razor for removing excess body hair to provide good contact and adhesion for the pads, resuscitation face shield, nitrile gloves, and a patient wipe. The suction unit is a lightweight hand-operated device used for cleaning fluids from the mouth and throat cavity to promote a clear airway. An oropharyngeal or OP airway is used to open and maintain a patient's airway. It does this by preventing the tongue from covering the epiglottis, which could prevent the person from breathing. OP airways come in a variety of sizes, from infant to adult. The airway needs to be sized and inserted correctly to maximize its effectiveness. Sizing is achieved by aligning the airway with the curve of the jaw to the frontmost row of teeth. Having first ensured that the mouth and throat are clear of any debris which may be forced into the patient's airway, insert the curved end towards the upper palate until resistance is felt, and then rotate 180 degrees into place. The bag, valve and mask allows the responder to ventilate and oxygenate the patient in the absence of normal breathing function. The unit consists of a mask, available in adult and infant size, non-return valve, and bag. Whilst the bag can be used with or without oxygen, it is preferable to supplement the oxygen supply to an unresponsive patient by connecting to an oxygen cylinder. For ventilation to be effective, there must be a good airway and efficient seal around the patient's nose and mouth. The administration of oxygen as a medical intervention enhances tissue oxygenation, which is essential for all normal physiological functions. The cylinder itself is constructed from a lightweight composite with an integral valve, contents gauge, and regulator assembly. Connecting the bag valve mask to the cylinder allows enriched oxygen to be delivered to the patient during ventilation. The cylinder regulator can be set to deliver oxygen at between 1 and 15 litres per minute. For effective ventilation of a patient requiring resuscitation, the regulator must be set to 15 litres per minute. Fully charged cylinders have a tamper-proof seal. The cylinder contains 460 litres and will last approximately 30 minutes. The Braden mannequin has an anatomically correct head and neck assembly to accurately mimic a patient's head movement and allow for the correct upper airway management techniques to be perfected. The mains or battery-powered mannequin has a series of interrelated lights which give real-time and recorded feedback of chest compression performance, blood circulation, and overall quality of the CPR being performed. Danger. Upon entering the room, the responder must check for inherent danger using the SIP protocol. Is the scene safe? Am I safe? Is the patient safe? Use all the senses, sight, smell, touch, taste, and listen to establish a 360-degree overview to assess for danger to you or the casualty. Response. Assess the patient's initial level of response using the AVPU protocol. Alert. Speak to the patient. Are they alert and fully responsive? Voice. If the patient is unresponsive, come close to the patient and, whilst gently holding the shoulders, speak clearly into each ear. Pain. If the patient remains unresponsive to your voice, use a controlled pain stimulus to generate a response, using either a trapezium squeeze or pressure with the thumb applied to the suborbital eye socket. If the patient fails to react, they are classified as unresponsive. Commence an airway assessment by first checking inside the mouth for any obstruction or debris, teeth or food matter for example, which may fall into the airway causing an obstruction. If there is no evidence to suggest C-spine trauma, the responder may perform a head tilt chin lift to open an occluded airway. If C-spine trauma is suspected, perform a jaw thrust to open the airway to minimize any movement to the head and neck. With the airway open, assess the patient's breathing for a minimum of 10 seconds by looking, feeling, and listening for 2 to 3 normal breaths and a consistent rise and fall of the chest to indicate normal breathing function. If the patient is breathing normally, place in the recovery position and monitor closely. It is not uncommon for a patient in cardiac arrest to perform agonal breathing. This abnormal, sporadic breathing is a brainstem reflex and is not effective respiration. If the patient's breathing is noisy, gasping, laboured, or inconsistent, this is not considered normal breathing and it may be assumed that the patient is in cardiac arrest. This information must be passed to fire control so that the responding paramedic can be updated as to the patient's status. Commence CPR. Establish the correct hand position by placing the ring finger into the crease of the arm socket and slide the hand across until the heel of the hand is in the center of the chest. Place the other hand on top and interlock the fingers. Position yourself with your shoulders above your hands. Using your body weight, compress straight down and release to allow the chest to return to its original position. Compression should be to a depth of around 1/3 of the total depth of the chest and at a rate of 100 to 120 compressions a minute. A second responder must prepare the AED. Continue chest compressions until the AED is ready to be applied. Cut and remove clothing, underwear and jewellery to expose the bare chest. Remove any excessive body hair using the prep raider if necessary. Remove the backing and apply the pads firmly to the front and side of the chest. The presence of a pacemaker need not preclude the use of the AED, and if visible, adjust the position of the pad 3 to 5 cm below the pacemaker. The AED will instruct the responder to interrupt CPR whilst it analyses the patient to determine if a shockable rhythm is present.
Analyzing heart rhythm.
During this time, the bag, valve and mask must be prepared and connected to the oxygen supply and set to deliver 15 litres per minute.
No shock advised.
If no shockable rhythm is detected, continue with cycles of CPR and ventilations at a rate of 30 compressions, followed by 2 breaths. If a shockable rhythm is detected,
Shock advised.
the AED will instruct the responder to move clear of the patient and press the orange button to deliver a shock.
Stand clear. Press the flashing orange button now.
The AED will then reanalyze the patient and instruct the responder to continue with CPR if necessary.
Begin CPR now.
The responder must continue with this cycle until the patient regains normal breathing and circulatory function, or instructed to do so by a clinician. The attending paramedic will require information relating to the event, including results of the primary survey and subsequent interventions, including duration of CPR and number of AED shocks administered. A well-rehearsed and effective CPR process will manually restore partial flow of oxygenated blood to the brain and heart. When combined with an AED to potentially restore the heart to a viable spontaneous rhythm, a very brief window of opportunity for complete resuscitation without permanent brain damage is greatly extended. For further information or clarification, contact a suitably qualified trauma care instructor.